Bismillahirrahmanirrahim. I, Lieutenant Colonel Nasir, welcome you all to my today's Belly and Laughs with Me session chapter 23, Early Assessment and Management of Severe Trauma, which was known to us as a ATLS, যেটা আমরা ATLS হিসেবে জানি, Advanced Trauma Life Support. This is discussed in chapter 23. So today we will discuss about the ATLS, Early Assessment and Management of the Severe Trauma. This chapter is very important from Belly and Laughs because every examination there may be a long question from this ATLS. Here we basically treat and identify the severely injured patient, and this is a total protocol or drill, so we should follow the every step of this drill. এটা একটা টোটাল একটা ড্রিলের মতো, আমরা প্রথম থেকে শেষ পর্যন্ত প্রত্যেকটা জিনিস আমরা ফলো করার চেষ্টা করব। In that case, if we follow the every step of ATLS, then we will not miss anything. It will need in our professional life, as we are doctor, we will be posted in different hospital, and as a junior doctor we of course work in emergency or emergency casualty or MI room, and we may face the emergency patient, trauma patient, because Bangladesh is a trauma prone country. So we should learn, and we should, I personally told that we should understand the ATLS. If we don't understand, if we try to only the memorize, then we cannot execute this ATLS protocol or implement this ATLS protocol in that situation. So I welcome you all to chapter 23 of Belly and Laughs, the Early Assessment and Management of Severe Trauma. Our learning objective of this chapter is how to identify and assess the severely injured patient. Basically, ATLS is always, we implement this protocol for trauma patient. So for trauma, suppose if there is a patient of MI, or if there is a patient of abdominal emergency, or if there is a patient of burn, in that case we have separate protocol. So this ATLS protocol is only for trauma patient. Okay, so our learning objective of this chapter is how to identify and assess to severely injured patients. Second, early treatment goal of multiple injury patient. Third, understand the role of pervasive hypotension, teneximic acid, and massive blood transfusion protocol, and understand the principle of basic controls, damage control surgery, and early total care. So let's start. Identification of severe trauma. If we start reading this chapter, we will see that for severely injured patient, there are with a multiple injury, this is a unique diagnosis and treatment challenge for this type of patient. So when we come across of a patient of trauma patient, this is a diagnosis many times is changed. Patient may have 2 injury, 3 injury, severe injury, or and then different type of injury. So it is a unique challenge and for diagnosis and treatment of this patient. So early assessment and management of severe trauma begins in the pre-hospital environment. So we should emphasize on this 2 words. This is pre-hospital environment, অর্থাৎ at the point where the accident happened or trauma occurred. If we have a emergency ambulance service, we send emergency ambulance, or nearby any medical personality, they must start the treatment for this type of patient. This is called pre-hospital environment. So here the early assessment and management of severe trauma begins in the pre-hospital environment. Many of these patients will be easily identified at the scene of injury. Yeah. And for warning, the receiving hospital allows the activation of the trauma team to prepare for the patient arrival. So here we can see that there will be a trauma team in the hospital where this patient will come. So before coming to the hospital, from the scene, if we inform the hospital or trauma team about the demographical information of the patient, then holo mechanism of injury is identified and vital sign, respiratory rate, pulse, BP, and GCS, Glasgow Coma scale. So we should inform the hospital before, when we are sending the patient to the hospital. That time we should inform the hospital and we should prepare the trauma team before coming the patient to the hospital. This drill is always practiced in our army hospital. In all of our army hospital, we practice this type of drill. Before coming the patient, we are ready in the hospital to treat them. So this is basically in advanced trauma life support or ATLS, or trauma patient should receive this type of treatment protocol. And then role of trauma team. This is not important for the examination, but in our personal daily practice life, when we work in a emergency or medical, or in a tertiary center, or in a village, patient don't know where to go. So if a patient come, then we must give the support. This is the role of trauma team, to apply the principle of advanced trauma life support, that is the ATLS, advanced trauma life support. What is the role? Principle. What is the principle? Principle number 1, rapidly identify and treat the life-threatening injuries during the primary survey. Yeah. So total ATLS is divided in 3 parts. Basically, in broad heading, ATLS is divided in 3 or 2 parts. This is primary survey, and then secondary survey, and there is another term used in this is tertiary survey. So primary survey, secondary survey, and tertiary survey. We basically learned today from this chapter primary survey, and in previous book, that is Bailey and Love's, in 26th edition, it was primary survey and resuscitation. So I will tell the student to read also 26 Bailey and Love's for this ATLS. But ATLS is more descriptive and more elaborate, I think, in Bailey and Love's 26th edition. And when we discuss the chapter, we will find that there are something which is not applicable for our country, for Bangladesh, like a poor country. So in 27, it is told that this is the gold standard, suppose like whole body CT scan, but we cannot do whole body CT scan in our country, even in the district level. So we should go for a some protocol from edition 26. Okay. Then principal advantage of trauma team is the it is written here that when assessing the patient of trauma, then we can work in sequentially, and we can work in together. That somebody may manage the, suppose anesthesiologist may assess and manage the patient airway. At the time, other team member can manage the patient breathing. So this is a treatment protocol for a trauma team. This is the importance of this trauma team. But in some situation of Bangladesh, we may face that we manage the patient by a single doctor. So in that case, we must follow the total protocol as a drill. So that is the advanced trauma life support. So come summary box 23.1. In that we will see the role of trauma team. We just read this for our maybe it is not important for the examination, but for our experience, for our understanding, we should read this box, summary box 23.1, role of trauma team. Always the simultaneous and efficient application of ATLS protocol to rapidly identify and treat life-threatening pathologies. So what are the principle of ATLS? Rapidly identify and treat. These two are the principle of ATLS: identify, diagnosis, and treatment of the life-threatening pathologies. That's why sometimes we are telling golden 1 hour in some patient of trauma patient, and this trauma team must be led by a more senior clinician. Okay, the more senior clinician from each specialty should attend the red code trauma call. So this is a protocol should be done in any trauma center, but where there is trauma patient is handled, they should be more specific for the treatment. The team leader should be trying constantly to anticipate the next move, or what should do next. It must be think by the team leader. Then primary survey, and I told what resuscitation. Okay, resuscitation. Okay, you can write it in your Bayesian laws. Primary survey and resuscitation, because in that part we do both simultaneously. Or we assess the patient and we give the treatment to the patient. We cannot write the history like other patient, that we will first assess, write down all the history and information, then start the treatment. This is not the protocol of trauma patient management. Trauma patient management have separate history sheet. If you see the history sheet of Dhaka medical casualty, they have a separate history sheet according to the ATLS protocol. There is a primary survey, secondary survey, and if needed there is a tertiary survey. So primary survey, in previous edition of Bayesian laws, it is written that primary survey and resuscitation, that we should do the survey for diagnosis and resuscitation simultaneously. So what are within the primary survey and resuscitation? This is started from C, then A, B, C, D. This is started from C and A, B, C, D. In Bayesian laws 26, there was no C. In Bayesian laws 26, it was A, B, C, D, E. But in 27, they add this small c before the capital letter of A. So in summary box 23.4, we found what is the drill. First, C. C means control of massive external hemorrhage. Here, this control of not any internal hemorrhage, but only for the external hemorrhage. This is added in the first. Then A for airway and cervical spine protection, B for breathing and ventilation, C for circulation and hemorrhage control, D for disability, that is neurological examination, and E for exposure, SS for the all other injuries. So we start from C, we end in E, and simultaneously we diagnose the life-threatening pathogenesis, and we will treat the patient or resuscitate the patient all together. So we must remember this C, A, B, C, D, E. C for control of massive external hemorrhage, A for airway and cervical spine protection. There are two always. B for breathing and ventilation. C for circulation and hemorrhage. D for disability and neurological status. E for exposure for to search other injuries. So we will discuss with every step from Bayesian laws. So C, here it is written, we just read that it is for external injury, and here C is written exsanguinating external hemorrhage. Exsanguinating external hemorrhage, that is the life-threatening hemorrhage for the patient. This is excessive hemorrhage or massive hemorrhage, external hemorrhage for the patient. And in before, first we started in the airway, but last 20 years in different conflict in war zone in the world, they assess that many patients die from external hemorrhage. That's why they add this C with this ATLS protocol. Okay, and most of the injury found in gunshot. In other case, we also can find this type of external hemorrhage. So then what we do to manage the external hemorrhage? This is the one after another. This come one after another. However, encountered in civilian, bleeding must be controlled. See, here is written, bleeding must be controlled immediately by application of pack and pressure. So first, what we will do to control the bleeding, we will pack and pressure. Second, directly onto the bleeding wound and artery. Then we can apply the hemostatic dressing that contain antigen for urgent local coagulation are now available. If these two failure, then we should apply the tourniquet, proximal to the wound. If simple tourniquet can be improvised to, if we have the pneumatic tourniquet, we use the pneumatic tourniquet. If there is no pneumatic tourniquet, then we can use the simple tourniquet. Then must be, what is the for, if tourniquet also failed, then the patient requires urgent surgical control of the bleeding. So you see here how we start. If we can manage a bleeding by pressure and packing, we will not go to the hemostatic dressing, or we can apply the hemostatic dressing. If we manage a patient by pressure and packing and hemostatic dressing, we will not go for tourniquet. If we manage a bleeding by tourniquet, then we will not go for surgical control of the bleeding. So this is the stepwise treatment. We must remember this stepwise treatment. আমাদেরকে এই stepwise treatment-এ মনে রাখতে হবে। অর্থাৎ আমরা একটা কাজ করে যদি আমরা ব্লিডিং কন্ট্রোল করতে পারি, তখন আমরা নেক্সট স্টেপে যাব না। এটাই হলো ATLS এর প্রত্যেকটা ধাপে এই জিনিসটাই আমরা শিখব। Okay, we will assess everything and we will go stepwise, one after another. If we can manage this thing by first step, then we will not go to second step. If we failed in first step, then we go to second step. If we failed in second step, then we will go to third step. So how we will manage the exsanguinating external hemorrhage? First, we must apply the pressure and packing. Then if we failed, then hemostatic dressing. If we failed, then we will apply the tourniquet. Then if we fail, then we should manage the surgical control of the bleeding. So these 4 steps we must remember. Next, same thing happened in also airway. Next important things is the airway and cervical spine protection. All trauma patients should have their cervical spine immobilization and protected the throughout. Every trauma patient we receive, we put a cervical spine, and we should not remove this cervical spine immobilization device before doing the X-ray or CT scan to confirm that there is no cervical injury. So every patient should have a cervical spine and the immobilization. Then we will assess the airway. If we that a compromised airway requires a stepwise progression, যেটা আমি কিছুক্ষণ আগে বলছিলাম। If we found a compromised airway, then we again start the stepwise progression, like the bleeding management. Okay, how we know that there is a compromised airway? In Balian Labs 26, it is written that if patient can respond to our vocal response, this is called vocal response. It is not written here. This is vocal response. Then we think that this airway is not compromised. If I ask the patient what is your name, if patient can respond, we don't need to go further step for the airway management. This is the things we must remember. But if we see that there is a foreign body in the mouth and patient cannot speak, foreign body or any blood or any saliva we can clean out. But if patient can speak to us, that patient can respond to our vocal response, patient have the vocal response, that time we will not go for further any step. So what is the stepwise progression? First, cleaning the airway. First cleaning the airway by suctioning, secretion blood, and followed by simple, then holo second simple airway maneuver, and that is the jaw thrust and chin lift. Third holo insertion of an oropharyngeal or nasopharyngeal air tube. Then holo advanced maneuver. This is the endotracheal tube অর্থাৎ intubation, endotracheal tube. So in last portion it is written that this endotracheal tube intubation must be done in expert hand. So what we will do for A? In A, we find that this is airway management, airway with cervical spine protection. First, we will apply a cervical spine immobilization to protect the cervical spine. This is one simple one thing we should do. And for airway, first we should confirm that that patient can have vocal response, patient do have any vocal response or not. If patient have compromised airway, so first we should go for stepwise progression. First step for what? Cleaning the airway by suction. Second, simple airway maneuver like chin lift and jaw thrust. How we can tell jaw thrust on chin lift or jaw thrust. Then holo insertion of a oropharyngeal or nasopharyngeal airway. If we cannot secure the airway by this maneuver, then we should go for advanced airway maneuver, and this is endotracheal intubation. So what I tell in this, see, same thing happened here. We should go for one after another. If we manage the airway by first, then we will not go to the second step. We can, if we failed the second step, we will go to the third step. So in examination, we should write this in point one, then second if failed, then two, then if not can secure the airway, then third, like that. Then come to the breathing and ventilation. All patients should have received high flow oxygen. অর্থাৎ প্রত্যেক পেশেন্টকে আমরা অবশ্যই হাই ফ্লো অক্সিজেন দেব। হ্যাঁ, then what is the difference between breathing and ventilation? Ventilation means this is generally people told that as a life support. হ্যাঁ, আমরা সাধারণত এটাকে লাইফ সাপোর্ট বলে জেনে থাকি ভেন্টিলেশন। অর্থাৎ দিস ইজ দ্য মেশিন ইজ রিপ্লেস দ্য ফাংশন অফ হার্ট, sorry, a machine is replace the function of lung. This is the ventilation. Yeah. Machine will give the breathing. If ventilation is not needed, then we can assess the breathing by our clinical examination. But every trauma patient should receive this high flow oxygen. এটা আমাদেরকে অবশ্যই মনে রাখতে হবে that every patient should receive high flow oxygen. Then if there is a patient is life-threatening chest pathology like tension pneumothorax, massive hemorrhage, flail chest, then we should manage it immediately. And we must have the facilities to insert a intercostal chest drain in this section. Yeah. So we should learn how to insert an intercostal drain to manage this type of patient. So after breathing and ventilation, we will move to the third stage, that is circulation and hemorrhage. C for circulation and hemorrhage. All patients required adequate intravenous access with two large bore intravenous IV cannula. অর্থাৎ every patient should get at least two large bore intravenous cannula. What is the meaning of large bore intravenous cannula? Every IV cannula have a number 14, 15, 16, 17, 14, 16, 18, and 20 and 22. Yeah, like that. So we must insert a 14 or 16 IV cannula, not 18, not 20. Yeah. Most commonly we should do large bore means 14 IV cannula. So we will establish a intravenous cannula for all the patient. Then we will draw the blood and we should send the blood for cross-match and other laboratory investigation. And if patient has hemodynamically shocked, then we should give we should replace the blood for blood, because any trauma patient have the hypovolemic shock. So we will see in the next summary box that fluid is not the treatment for this patient. Blood is the treatment of the patient. So after establishing the IV cannula, we will draw the blood and send the blood for cross-matching and other important laboratory investigation. We cannot take the blood 2 or 3 times. হ্যাঁ, আমরা 2 বার 3 বার 4 বার কিছুক্ষণ পর পর ব্লাড দিতে পারবো না। আমরা IV cannula established করে we will draw the all blood for all necessary blood investigation and blood grouping and cross-matching. And here another thing is told that pelvic binder should be applied in hemodynamically unstable patient and before excluding the pelvic fracture by X-ray or CT scan. Then come to the D. What is the D? D is disability, that is neurological examination. We must assess the GCS of the patient. With the GCS, we assess the pupil for size and reaction to the light, and the patient observed for determine whether they are moving all the limb. Orthat, we must go for neurological examination, uh, and most important neurological examination is GCS and assessment of the pupil. Then we will check the E for exposure. Orthat, we will look for any other injuries patient have or not. And for moving this patient, there is a technique. This is called log roll technique. Log roll technique. So we must remember this. We must learn this. There is a picture in another chapter for log roll, how we will move a patient. 5 or 6% at a time should move the patient. That patient don't have any thoracolumbar, or that is the spinal cord injury, should not be happen to the patient. Then so this is all from the primary survey. Okay, so from primary survey we first discuss C, then A, then B, then C, then D, then E. So this is all about the drill. We should not miss one, or we should not cross one after another, that first we start the neurological. No, this is a drill. We should start from beginning and we should practice up. We can do it simultaneously. That in a trauma team, if have a anesthesiologist and have a neurologist, in that case anesthesiologist may assess the airway, and neurosurgery doctor can assess the GCS and other neurological deficit. In otherwise, we should follow this protocol one after another. This is important. Next, after this primary survey and resuscitation, we go for the secondary survey. After that, we go for the tertiary survey for some specific condition. Now, first I discuss from first to last about the ATLS protocol. Now, I don't discuss about the investigation. Okay, what investigation we should have in the primary survey and resuscitation. Now I will discuss that. Before that, I just say some word about the summary box 23.2. This is for severe hypovolemia. Tenexamic acid. In Balian labs, their point is written in favor of tenexamic acid. So all traumatized patients should receive a tenexamic acid. Okay. Then trauma center should establish massive transfusion protocol, or that what will be our massive transfusion protocol. We should follow that in every trauma center, but or where we treat the patient. Then hypovolemic trauma patient should be resuscitated using the blood and blood product. যেটা আমি কিছুক্ষণ আগে বলছিলাম, we should not use the fluid for the resuscitation. This is hypovolemic shock. This is shock due to the loss of the blood, so we should use the blood and blood product. Before managing the blood and blood product, we can use only some crystalloid for initial management. Okay, and this should be limited. Next, investigation. What investigation we will do in the primary survey? It is not written in separate. In Balian labs 26, it is written in separate. So what is written? First, blood grouping and cross matching. First investigation, blood grouping and cross matching. Second investigation, other emergency blood investigation like CBC, then creatinine, then RBS, then serum lactate, like that. Third, trauma series X-ray. It is not written in Balian labs 27, but it is written in Balian labs 26. We must write in the examination, because in our country or in poor country like Bangladesh, we don't have the facilities of whole body CT scan. So we should not forget about the trauma series X-ray. What is the trauma series X-ray? Trauma series X-ray means X-ray of the cervical spine, X-ray of the chest, X-ray of the abdomen and pelvis. So these three X-ray we must do. And other, if patient have injury in the leg, we will go for the X-ray of the leg. If patient have injury in the hand or upper limb, we will go for the X-ray for the upper limb. So this is trauma series X-ray. Then what is the 4? Number 4 is the FAST. FAST. Focus abdominal sonography for trauma, অর্থাৎ ultrasonography of the abdomen for the diagnosis of any accumulation of blood. Then this is fourth, and fifth investigation is whole body CT scan, whole body CT scan. So this some we can read in your book, right? First investigation, what is the investigation for primary survey necessitation? This is blood grouping and cross matching. Second holo other important investigation for the blood, like CBC, serum electrolytes, creatinine, RBS at a whole. Third, we should do the trauma series X-ray. And fourth, we should do the first ultrasonography of the abdomen. Then fifth, this is the whole body CT scan. So আমরা এই জিনিসগুলো মনে রাখার চেষ্টা করব। Though in Bellion Labs 27 it is written that you can see that whole body CT scan from head to pelvis with IV contrast, or the CT scan should be head and pelvis with IV contrast, is the gold standard investigation for severely injured patient. But we cannot implement this type of protocol in our country because we are poor country. We don't have all the facilities in all the upojela and district level. So we will do the X-ray. Yeah. And there is no role of selective scanning of the body, or that we will not do some part of the CT scan of only the brain, CT scan of chest. We should do the whole body CT scan. That's why it is treated whole body CT scan. Then whole body CT scan is a time critical investigation and should be obtained as early as possible in resuscitation of the severely injured patient. Yeah. And then any patient undergoing immediate trauma laparotomy. এখানে যেটা is another thing here, it is written, that is we'll see in the next chapter. There is a emergency surgery that is written in the first, damage control surgery. Okay, that is written in the first, damage control surgery. So where we will go for damage control surgery, in that case we may not be able to do the whole body CT scan. It should be remembered, any patient undergoing immediate trauma laparotomy after blunt trauma without a whole body CT scan should have a pelvic binder applied and not removed until the pelvic fracture is excluded. Such patient should have a immediate pelvic radiograph. If we do the radiograph, we will do the all trauma series X-ray. So that is about the investigation of ATLS protocol. It is not written in the stepwise, so you can written this 1, 2, 3, 4, 5. And this is my last slide today. This is Glasgow Coma scale. That's this scale maybe you will find in another chapter as it is here. So I bring it to discuss with you. In Glasgow Coma scale, we have 3 things to assess: this best eye response, best verbal response, then holo best motor response, অর্থাৎ EVM. EVM. In E there is a 4, it is 5, it is 6, অর্থাৎ this is total 15. Okay, this is total 15. Any patient may be dying, but he also can score the 3. So in trauma patient, a death patient, he is not a GCS 0. GCS never will be 0. GCS will be at least lower point of this scale is 3 and upper point is 15. So in eye response, if eye open spontaneously, he will get 4. In eye respond on speech, so we can memorize like that. This is spontaneous, then speech, then holo pain, then holo no. 4, 1, 2, 3. Then same as verbal response, oriented, then confused, then inapproved word. If he can only sound a word, then it will be 3. If he can only make the sound, then it will be 2. And then motor response, obeys command, localize the pain, withdrawal of the pain, flexion, extension, and no response. So we should practice this Glasgow Coma scale, and if we don't practice, we cannot remember this Glasgow Coma scale. So today this small chapter and I think you will read this chapter very carefully and you will try to understand this chapter because it is important for all examination. Next day I will discuss about the torso trauma chapter, that is chest and abdomen. So thank you everybody. Good night.